Oh God. Yeah.
Okay, I hope everybody had a good weekend. We're going to get started with our capillaries now. What we're going to be focusing on for most of today is what's called net filtration pressure. So we're going to be picking up. Last time we were talking a little bit about what can get across capillary walls and can't. Now we're really going to be focusing in on the movement of fluid. Just a reminder, when we're talking filtration, we're talking about fluid moving out of the capillaries. When we're talking about absorption, or we'll see sometimes here reabsorption. For the purposes of this unit, we don't need to distinguish between absorption and reabsorption. When we get to the renal unit on the kidneys, we will kind of be distinguishing those two things. So for our purposes, absorption or reabsorption into the blood, filtration out of the blood. So what we're going to be trying to do as we look at the capillaries is to figure out overall on net which direction is the fluid moving. And this is important because it's going to help us understand why tissues swell sometimes, right, during injuries or immune responses. That's due to these different pressures changing and changing the direction and amount of fluid flow. So we're going to be talking about something called Starling forces. And these are different than our Starling curves in the heart. Totally different concept, not actually related. But Starling forces across capillary walls. We're going to have 4 of them in total, but they come in 2 flavors. Okay. So we're going to be thinking about hydrostatic pressure and osmotic pressure. Okay. We've seen this word hydrostatic before, or at least I've said it out loud once before. I don't know if it was written down. Does anybody remember where we saw that before? There's those figures from the book where we have those columns of water, right? Where we had columns of water with their different heights. Right. So these things were called hydrostatic columns. So when we think about the hydrostatic pressure, what we're talking about is the pressure exerted by the fluid, either in the capillary or in the space around the capillary, so in the interstitial fluid. The osmotic pressure has to do with solutes dissolved in the fluid. Now, for our purposes, because we're just figuring out which way the water moves, we only need to think about non-permeating solutes, so things that can't get across our membranes, because those are the ones that are going to exert a pull on water. If it's something that can move across a membrane, it can just move on its own. It's not going to exert a pull on the fluid. So only the non-permeating solutes matter to us now. This means that we're also going to sometimes see this called oncotic pressure. So osmotic pressure and oncotic pressure for us are the same thing here. We're talking about the pull on water. Oncotic means we're talking specifically about the fact that proteins are what's doing that pull. So sometimes your book or slides will refer to one or the other. They're the same force here. So we're thinking about the hydrostatic pressure basically as blood kind of trying to push out of the capillaries. Right, so that should be your kind of like gut idea of what that means. We're thinking about our osmotic pressure as like proteins in the blood trying to pull water towards the blood. That's kind of what we're doing. But as we add everything together, we're going to see that we'll have a hydrostatic pressure for both the capillary and for the interstitial fluid. And the same thing for the osmotic pressure. We'll have a number for within the capillary and a separate number for within the interstitial fluid. So when I said 4, that's what I meant. We think about these two things in two different spaces. Okay. So we're going to start out by thinking about the hydrostatic pressure. Now, the hydrostatic pressure actually changes depending on where in the capillary we are. So hopefully we remember that our capillary is going from an arterial. I'm just going to draw one capillary, but we know it's a bed. Changing because we have oxygen coming out of it, carbon dioxide going in, or attaching to a venule. So as this happens, spoiler alert, we are going to see that fluid moves out of the capillary and into the tissue. So this means that we're going to have a slightly different pressure of the force of that fluid inside the capillary if we're starting at the arterial end versus at that venule end. And this also has to do with some of the different properties of our arterial first phase. So at the arterial end, so here, say, inside the capillary, we have a pressure, a hydrostatic pressure of 38 millimeters of mercury. I would say pressure of the capillary. That's how we're going to indicate hydrostatic pressure, is with this P equal to 38. But by the time we get to the venous end, we're going to be down to 16. So this is the only one of these forces where we're going to distinguish the arterial end versus the venous end. For all our other forces, the number is just going to remain the same wherever we are. It's only for this hydrostatic pressure of the capillary that it matters where we are within the bloodstream. So when we have a positive number for any of our pressures here with the hydrostatic pressure, whether it's 38 or 16, what we're saying is that that is the force. Maybe I shouldn't have drawn the arrows that way. I'm realizing that might be confusing. So what we're saying is that this is the force that the blood within the capillary is pushing out of the capillary. All right, so this is why it favors filtration, because filtration is the movement of fluid out of the capillary, and this is the blood pushing on the walls, and if it pushes hard enough, they pass into that interstitial fluid space. Okay. Now, the interstitial fluid next to the capillary, so I'll draw some tissue, which your book usually draws as yellow, so we have this space here. This space also has a hydrostatic pressure because there is fluid in it. Anywhere we see fluid, we're going to have a pressure, but it's super low. So between 0 and 1 millimeter of mercury, so pretty negligible. But that force of that fluid that does exist, if we had to say what direction it goes, right? Like a little water molecule here, would be pushing against the outside of the wall, trying to get into the capillary. So we would say that that pressure favors reabsorption. Now, looking at just these facts about the hydrostatic pressure, which direction would you expect fluid would go? Which would win if we were just considering these forces, filtration or reabsorption? Yeah, exactly. We can see that these forces for filtration are much greater than our force for reabsorption when we're just looking at these hydrostatic pressures. And that's conceptually what we're going to be doing even as we add in the osmotic pressure. We're just kind of adding up which number is bigger, the forces pushing stuff out or the forces pulling stuff into the bloodstream. The larger numbers are greater force.
Are these numbers set in stone, or are these just example numbers?
These are typical numbers.
Okay.
Yeah, so we'll see these specific numbers a lot. Changes in blood pressure could change these numbers, right? Because that would change the blood pressure of the blood inside the capillary.
Okay.
But this is a pretty typical value.
Okay.
Great. So just like you told me, especially at the arteriolar end, we take that pressure within the capillary. All right, so that was our P cap. Minus our pressure in the interstitial fluid. 38 minus 1 is 37. So we have filtration. Okay. We see overall for the hydrostatic pressure for the venous end, we also have a number that favors filtration. The reason we haven't written it in here next to it is that for the venous end, that osmotic pressure is going to make a big difference here. So the overall thing that we observe at the venous end isn't filtration, even though the hydrostatic pressure would make it filtration. So we'll take a look at that osmotic pressure next. So when we're talking about the osmotic pressure, or the oncotic pressure, because it's pretty much from our proteins. Draw us where we are. Sorry, tissue. So pressure of proteins inside the capillary. These proteins exert a pull on water towards them. You remember way back when we talked about osmosis in like our first unit back in September or October, I don't remember exactly when it was. We talked about the fact that basically water wants to move towards solutes to water them down, right? We often see swelling in response to this if we're just looking at a single cell, right? So non-permeating solutes pull fluid towards them. Okay. So these solutes in the capillary, these proteins, are creating a pull on the fluid from the interstitial space. Okay. So this, we say this favors reabsorption because we're trying to take that water that's in the body and or in the tissue space and pull it back into the bloodstream. Okay. So we're going to denote that as pi. So that's the oncotic osmotic pressure of the capillary. And we say it's of the capillary means we're talking about the stuff that is in the capillary is what's responsible for this force. The interstitial fluid does also have some solutes within it. Again, we're going to see not a terribly large force, but those fluids exert a pull on the fluid in your plasma to move towards them as well. So that's again about 0 to 1 millimeters of mercury. But for the direction, it favors filtration, just not a very strong force. So if we look at the osmotic pressure gradient, we see we have osmotic pressure from the capillary, 25 millimeters of mercury pulling fluid into the capillary at the reabsorption, versus 0 to 1 for filtration. So that's this one. That would be our pi IF for interstitial fluid for filtration, giving us a total osmotic pressure gradient of 25 millimeters of mercury, favoring reabsorption.
Why wouldn't the protein just take the fluid before it leaves the artery instead of pulling it back through?
I'm not sure I understand your question.
Well, the fluid that's coming from the artery
Mhm,
is getting pulled out by the hydrostatic pressure, and getting pushed out
mhm.
by hydrostatic pressure. So the proteins are in the arterial, absorb the fluid from the interstitial space. So why wouldn't they just pull the fluid that's trying to get pushed out?
So we're going to end up adding these forces together. So it's not like the hydrostatic pressure does something first and then the osmotic pressure. It's all happening at once. So we're going to be combining them for a net filtration pressure. Does that answer your question?
Yeah.
Okay.
So the osmotic pressures are essentially like summed together, and then the hydrostatic are summed together as well, the two categories of each.
Yes, we are going to be summing them all together. How you want to do it exactly
But I just mean
may change. Yes, yes, the way it's in your book for the equation, I prefer to sum forces for filtration and then forces for reabsorption, because that makes more sense to me. But the order you do them in doesn't necessarily matter, if that makes sense. Okay. So we're going to put them all together now. Okay, so looking at our capillary, we have our forces here on the side. So I'm going to draw on those forces. So our hydrostatic pressures are the P, the osmotic pressures are the pi. Okay. So hydrostatic pressure, capillary, blood, trying to push out. 38 here at the arteriolar end. Hydrostatic pressure of the interstitial fluid. Water trying to push in. It's about 1. And we also have to pay attention to our osmotic pressures at the same time. Our osmotic pressure is always the pi. So pi cap is referring to the pressure of those solutes inside. So they're pulling water towards them, their force for reabsorption. Equal to 25. And then anything in the interstitial fluid. Cut is pulling water towards it. And that's about 1. Okay. So for the summation, we're going to calculate a total force for all of these. sorry, you are right. I meant interstitial fluid here. Thank you. Okay. So this is kind of like when we were doing electrochemical gradients, which I know is maybe not what you want to hear, but we're looking for just one number overall that's going to control the direction of fluid. So the way I like to do it, right, is to take all our forces for filtration and then subtract all our forces for absorption or reabsorption. So to do that, I'm going to look at the arrows, right? So filtration is which direction? Out of the capillary or into the capillary? Yeah. We're looking for anything out of the capillary. So that's going to be the hydrostatic pressure of the capillary, as well as the osmotic pressure into the capillary. Sorry, the osmotic pressure of the interstitial fluid out of the capillary. Okay. So and then we take our forces in the opposite direction. So we're going to take the hydrostatic pressure of fluid in the interstitial space, pushing towards the capillary, as well as that oncotic pull, that osmotic pressure of the proteins in the capillary pulling water towards them. We're going to subtract those. We're going to subtract 25, and we're going to subtract 1. So I'm just going to distribute that negative immediately. So subtracting the hydrostatic pressure of the interstitial fluid, and then also subtracting our osmotic pressure, the capillary. So subtracting 1, subtracting 25. And this is going to get us our overall force for filtration. Does somebody want to do that math for me? 13, great. Okay. Cool. All right, so this is our force for filtration in this situation. Does everybody kind of follow how we did that? So this is what we're going to be doing when we're talking about the net filtration pressure. We're saying we're summing together these 4 forces. So we're thinking about everything that's pushing water out towards the interstitial fluid, everything that's pulling water in towards the capillary to come up with an overall number. So this is the arteriolar end. So you can immediately see, right, that the fact that we had a difference between the hydrostatic pressure of the arteriolar end and the hydrostatic pressure of the venous end is going to make a difference for our overall result, right? Because we have to take into account everything, including that oncotic pressure of the capillary, which is exerting a pretty strong pull on fluid towards the capillary. This is just a little diagram of the directions of these pressures. We have the hydrostatic pressure of fluid in the interstitial fluid pushing in towards the capillary, our pressure of fluid inside the capillary, that hydrostatic pressure pushing out. And then we have our 2 pulls from non-permeating solutes. We have that pull of the interstitial fluid, proteins pulling towards that space versus the pull of proteins in the blood pulling towards our capillary. So these arrows, I should note, aren't denoting like venous end versus arteriolar end. They're just to show you the directions here. Overall, we're going to kind of rearrange the forces, and we're going to see that at the arteriolar end, we're going to have net filtration at the arteriolar end. When we add together all these things, we're going to have a bunch of fluid moving out of the capillary and into that interstitial fluid, so into our tissue basically. Then when we get to the venous end, we're going to be reabsorbing fluid as we move into the veins. We refer to that math that we just did as our net filtration pressure. So the equation we just went through, our net filtration pressure adds together all our forces for filtration and subtracts all our forces for absorption or reabsorption. I always do this sort of intuitively and thinking about the pressures rather than memorizing the specific equation, because I find that helps me internalize it better. But if you wanted to memorize another equation, you might memorize it like this. So our net filtration pressure is the hydrostatic pressure of the capillary plus the osmotic pressure of the interstitial fluid, subtracting out our osmotic pressure of the capillary plus our hydrostatic pressure of the interstitial fluid. If you're memorizing an equation, remember to distribute this negative. All right. So you're subtracting both of these added together. All right. So the only difference between our equation here is they approximated that oncotic pressure of the interstitial fluid is 0. So we said it was 1, so we got 13. They said it was 0, so they got 12. At the venous end, at this look later, we'll see that because that hydrostatic pressure in the capillary is 16 instead of 38, no longer big enough to fight against the force of those proteins pulling fluid in towards the capillary. So we get a negative number when we run our equation. Okay. So if we get a negative number for net filtration pressure, that means we don't have filtration happening, we have absorption happening. So if we have a negative number, it's the opposite of filtration, meaning the opposite direction of the fluid. Overall on net, throughout the body, we have more filtration than absorption happening. So we do flip directions when we get from the arteriolar end to the venous end, but it's not even. Overall, we're filtering out actually 3 liters a day of fluid. Now, fortunately, we do accommodate for that. The lymphatic system, kind of part of your immune system, is going to be picking up excess filtrate. It's going to return it to the circulation. So it's not like we lose that fluid permanently. It's just going to be taking a different route to get back into our circulatory system. I'll talk about lymphatics more also when we talk about digestion. It has an interesting relationship to lipids. So there are factors, as you were asking, that can change these pressures. One of the most common is standing on your feet. So when we were looking at that video on the first day about the man who was having trouble with falls and with his blood pressure as he stands, this is because standing on your feet increases hydrostatic pressure actually in your lower limb, right? So that that blood sort of pooling, right? That gravity pulling on the blood increases hydrostatic pressure. Other things that can change these forces include damage to the capillaries, right? So if suddenly you don't have your nice little loop of endothelial cells around the capillary. You have a gap, right? Got cut. All right, this is a terrible knife, okay? But if you now have a hole, if you have a gap in this area, proteins and fluid are now able to leak out, right? So this is going to change both of those types of pressure, but especially the osmotic pressure, depending on how much protein we leak. Histamine, if you ever take antihistamines for allergies, histamine actually increases the ability of proteins to cross capillary walls. So if we have histamine in our body, that means we have more protein hanging out in that interstitial fluid, which is why you can get swelling with histamines, why you might take an antihistamine to bring down swelling, right? Because those proteins in those leaky walls are now exerting more of a pull on the fluid towards them and swelling this interstitial fluid, swelling this space. Different diseases can also affect these different pressures. So liver disease decreases the plasma proteins, so that's going to decrease that capillary oncotic pressure. Right? So it's going to decrease that pull back in to the capillary.
So, I have a question.
Mhm.
Hydrostatic pressure in NFP,
Mhm.
that, like, why people wear compression socks?
Yeah, yeah. And that also has to do with some blood pressure regulation, because we'll talk about, we do have sort of reflexes that allow us to adjust for that, right? We don't all faint when we stand up. Only some of us, only sometimes. But yeah, compression socks help with that if those usual sort of regulatory mechanisms aren't working well.
Is that like a physicality that it's just, there's not enough room for it to, or does it like, there's the diameter room?
Yeah, so we're going to be talking about like, the muscular pump and how veins return blood to the heart. And one of the ways that we're going to see that works is actually like your muscles squeezing on the veins. That compression pushes blood back up towards your heart. So yeah, the compression garments kind of have that same effect a little bit. They're increasing pressure on the veins and then helping you push blood back towards the heart. Yep. Okay. A couple more things that you might see affecting filtration and absorption in the capillaries. Kidney disease is going to increase blood volume, therefore increasing blood pressure, therefore increasing our hydrostatic pressure. Also decreases plasma protein, so that's decreasing that oncotic pressure back in towards the capillary. And heart disease, depending on the type of heart disease, we'll see different effects. But one of the things that we see common in heart disease is pulmonary edema. So that's going to be swelling in the lungs. So that's going to also be a result of more filtration happening there, sort of build up of fluid in the lungs, around the lungs. Whenever we see this word edema, I should say, edema is referring to a swelling, basically an excess of fluid in that interstitial space. I'm going to go ahead and do a few questions. So take a minute or so to read this question and jot down your answer. Bless you. Hopefully everybody got This is an example that we just ran over. So if you cut yourself, tissue in the area swelling, you're releasing histamine in response to this damage. And that means we have more proteins moving out of the blood into the interstitial fluid. So this is going to increase that osmotic pressure of the interstitial fluid because those proteins are pulling water towards them. That's what's causing the swelling when you get cut. Yep. Question? We're really just trying to identify here what isn't one of our Starling forces. So pressure of the fluid inside and outside the capillary, we know is our hydrostatic pressure, PCAP, and PIF outside the capillary would indicate in that interstitial fluid. Our osmotic pressure of caused by solutes that can't pass out of the capillaries would be that pull into the capillaries, or osmotic pressure of the capillary, high cap. Solutes that can't pass into the capillaries means they're still in the interstitial fluid. So what we're referring to here is IIF, interstitial fluid osmotic pressure. And thankfully, we do not have to think about ions when we're thinking about Starling forces. Okay? So the ionic driving force, ions in the blood, this is not anything to do with our filtration pressure. We're done with ions for the moment. Take a sneak peek at the venules and veins. So we have a little more time when we get to blood at the end of the unit. So here we're looking at a comparison of an artery versus a vein. You can see some of the features we talked about already. You can see, especially on the artery, we talked about the fact that we have these thick walls, they're muscular, they have a lot of fibrous tissue, they're very elastic, they hold pressure really well. On the venous end, we can see these walls are thinner, veins are still large, but they have these thin walls, which is going to be really important as we start to think about them as being a volume reservoir, able to hold a lot of blood. Another thing we're going to notice about the difference between the anatomy of an artery and a vein is something you probably haven't been able to see yet, which is that a lot of veins, specifically our peripheral veins, are going to have valves. Okay? So this is a valve inside the vein. Okay. So the way our veins are going to work, we're going to have pressures that move blood up towards the heart, but they're going to change based on our behavior. So those pressures are going to be things like physical movement of your body, things like your breathing. So blood is going to want to backflow sometimes, like we saw in the heart, right? So these vein valves are going to be really important in the veins so that as we move water back towards the heart, it doesn't just keep pooling in our feet every time we stand up or every time we relax our muscles. Our arteries don't need this because we have that push of blood coming out of the heart. And a lot of our systemic arteries are trying to get away from the heart, which is high up. So this is a difference between these two parts of the cardiovascular system. So coming out of the capillary, remember that thus far we have, right, our heart, our arteries, our arterioles, Remember the arteries, we're thinking about pressures and keeping pressure in those walls. The arterioles, the main thing we were thinking about was how they regulate resistance, specifically total peripheral resistance, but also resistance to specific organs. I added on our capillaries, their filtration and absorption. Right, so their balance of fluid between the blood and the tissue. Capillaries, not the best speller. Okay. So now we're to the venules. So this is our final part of our microcirculation that we hadn't talked about yet. And then we'll have veins returning to the heart. Our venules are smaller than our arterioles. Their main role is to connect the capillaries to the veins. So because we're not regulating resistance anymore, like we were in the arterioles, we're not going to see a lot of smooth muscle in those walls. We're not making a lot of changes to the radius here. There's a little bit of exchange still happening between the blood and the interstitial fluid as you move into the venule. So they're behaving a little bit like a capillary as they start to receive that blood from the capillary bed. But otherwise, they're small, pretty thin walled, they're connecting us to our veins. The veins look kind of like arteries when you see them in a body, in that they're large in diameter, so they have a large amount of space, which means we know that they're going to have relatively little resistance, right? Because we know we have that trade-off between radius or diameter and resistance. Thin walls, we're going to think about the relationship to a physical property of compliance that we talked about before. So we'll come back to that. We also want to know now, we didn't know before, they have those valves that have unidirectional blood flow. So our additional note here is that those valves are present in peripheral veins, but not in central veins. Anybody have a guess of what the difference between a peripheral vein and a central vein might be? Want to name one of either type? Would be an example of a. Okay. It's fine. You guys don't know. I just was wondering whether you knew. Okay. Yeah, perfect. Yeah. So our peripheral veins are going to be anything out in the periphery, and for purposes of veins, what we mean is anything outside of the thorax. Right. So peripheral veins is everywhere else. Anything in the thorax, specifically, we think about the vena cava, both superior and inferior, if they're returning blood directly to the heart, and central veins. So once we're in the thoracic cavity near our heart, we're not going to see these valves anymore, but everywhere else out in the body we go. Veins are compliant, which allows them to act as a volume reservoir. So we might say they have high compliance, right? Because when we talked about arteries, we specified that they have low compliance. So this means they're behaving in the opposite way to the arteries that we talked about earlier in the unit. So this means that as we put more volume in a vein, as we put more blood there, we don't see much difference in the pressure. So those thin walls expand pretty easily. They're not clamping down on the blood. That is what compliance means. So we're going to see that the veins actually hold most of the blood in your body, like 60% of your blood at any given moment is in the systemic vein. So here we see a graph of compliance. So you can see compliance is higher in the veins, right? We can see that line is higher. But the way we might read this graph is by looking, let's say, at a specific pressure. Let's start with a pressure. So we'll start with this line. So at any given pressure, this artery will hold a lot less volume than this vein. Right? There's more volume in the vein for that pressure. Of Or we might read it the opposite way for a volume. All right, let's look at volume 1. Okay. So volume 1 will give us a really low pressure in the vein, but as we follow it out, that same volume would create a pretty high pressure in an artery. You can kind of think about this either way, but what we're thinking about with compliance is this trade-off between pressure and volume. Right? How much pressure adding some volume creates. In an artery, it's a lot. In a vein, it's not very much. So here's a breakdown of where most of your blood volume is. So you can see that those systemic veins and venules, adding them in there, take up a ton of your blood, 60%. Systemic arteries and arterioles only have about 15%. In your lungs, you have about 12%, those pulmonary blood vessels. Heart at any given time has 8%, capillaries 5%. So veins are really important that they can hold this volume. And it's going to be important to our blood pressure as we get into that on Wednesday. This will be one of the last concepts we'll go over for today. But when we think about veins, their job is returning blood to the heart. We want to know how they do that. Right? So one of the ways that veins are able to return blood to the heart is by using something called the skeletal muscle pump. So skeletal muscle, remember we distinguish skeletal muscle from cardiac muscle, from smooth muscle. Those are our 3 types of muscle. So we're talking muscles that are attached to bones that we consciously, voluntarily move. So this works because out in our peripheral veins, leg, this is a foot, don't judge me. I can count, no I can't, I think that's 5 toes, whatever. Okay, so out in our body, right, we have our veins, and they have valves. I'm going to draw a valve here. So when you use your skeletal muscle, when it contracts, it bunches up, right? And as it bunches up, it pushes in on that vein, right? And so you can think about this like squeezing anything, right? Like if you squeeze any sort of tube with fluid in it, if you squeeze in the middle, it's going to push pressure out towards either end. Okay, so these valves are one-way valves. So when the muscle bunches up, when it contracts, creates pressure, pushing blood this way. Because this is a unidirectional valve, blood can flow in that direction. That's the direction we want it to go, back towards the heart. But any blood that's being pushed down towards the foot here is going to bump into that valve and bounce off. Right? And this way, we're going to squeeze blood sort of one segment by segment back up towards the heart. Okay. When we relax our muscle, right, the pressure drops because this vessel gets wide again. So the blood's going to want to move back, but it can't because we have this valve. All right, so we'll pick up here next time, getting a little bit more about the skeletal muscle pump, respiratory pump, before I move into lymph and blood pressure again.